him a bit. But we have 2 different reports that we submit to the judge, and we generally do that anywhere between 3 and 5 days before the hearing. Currently with our program, our orders are established for 1 year at a time, and then we see individuals quarterly in between that year. So before each hearing, we probably see about 4 to 6 individuals on any given hearing date. So that's how many reports our court case manager generates. So between the court case manager and our community provider, which is HopeWorks, they each submit their own report, whereas HopeWorks really focuses more on the treatment plan and the treatment component of how that individual is doing. And our court case manager focuses more on the legal side. They check in to see if they're picking up any new charges, or if they come to us with pending charges, what is the status of that? And then she also tracks her communication with both the individual, their family members, if they have treatment guardians, anybody outside of that that's involved in that treatment and care. So that's kind of the routine that we're currently following. And because we're only seeing individuals on a quarterly basis to cover any period of time where incidents may be occurring in between, then we have this really quick 1-page form. We call it a notification of important concern. So if an individual were to be arrested or hospitalized or become homeless, some of those bigger issues, one of those forms is completed and submitted to the judge in between those quarterly hearings. So that way, if it's determined that maybe we need to bring that individual back in sooner, we have the option to do so.
And when the judge gets one of those notifications, will the judge typically take some action on that, like call an unscheduled conference to learn more about what's happening?
We have a couple of different options that we list on those notifications. Sometimes a lot of time it's our treatment provider who's providing those notifications, and they'll really give their clinical recommendation on if they think action needs to be taken. And so we have a couple of different options that could be checked off with that notification, where it's maybe just a notification to the court, or there could be a recommendation to bring that individual in sooner. Or maybe we need to come together as a team to staff the case. So there's a couple of different options on that notification to kind of give the team and the judge a picture and an idea of what our next step should be.
Yeah. So the person filling it out will be the driver of what happens next. It sounds like that they will actually ask the judge what they would like to happen next.
Yes.
Gotcha. That's interesting.
And then there are times where during our quarterly hearings, an individual is struggling and maybe not doing as well as they had in the past, or is backsliding. We may decide as a team in that hearing, let's see you again in a month. So that may not need to drive that notification of concern. But if there has been a few that have come in prior to that hearing, and we're hearing in that hearing that the individual isn't doing well, then the judge may decide in that moment, I want to see you again in 30 days or 6 weeks, whatever that might be.
Gotcha. Yeah, we'd actually love to get a copy of that form, Laura.
Sure.
If you can share that with us.
I sure can.
Yeah, thank you. We'd love to put it in our document database if you guys were okay with that for
Sure.
copy.
Thanks, guys.
Awesome. Anyone else want to speak to whether reports are going in writing to the judge?
I will.
Yeah.
This is Judge Anderson from Nevada County, California. Our AOT orders are only for a duration of 6 months, subject to maybe possible extensions, but it's a 6-month limit. We get status reports on the day of status review hearings, which are as frequent as 1, 2, or 3 weeks, depending on the need of the individual. And they have a brief background, a brief status of how they are in compliance with the treatment plan, and then a section of recommendations. And as far as preparing those, probably Carol Stanchfield, I believe, is on this morning as well, and she could be specific as to those because she initiated the form that we use.
You want to take that baton, Carol?
Sure. I thought maybe Heather would jump on because she's so involved in those currently. I think Heather's on the call as well. But yes, I think initially the law says report to the court in 6 months. However, we felt that it was important to provide more frequent collaborative court contact. So the team, Judge Anderson and the treatment team, work together to schedule those more proactively as we saw the need. And so beginning with the first status hearings, we would provide a status report to the judge and to the attorneys, and with, just as Judge Anderson said, I mean, basically, I think the first form included a section where you could include the factors that led to the referral, and then subsequently, how are they doing in terms of the treatment plan, engaging or not, or struggling with some components of it. And then recommendations that maybe we want to come back sooner for a period of time because of some other additional circumstances that are in place with the individual on the order. So certainly something that is individually addressed. None of them are exactly alike, but they are structured in a similar way. The form is very simple, and it really is the kind of a combination of an extension of a treatment plan with a sense of, you know, kudos to this person. This is going really well, or a little bit more difficult engaging with some component of it. And it's also an opportunity then for the court team to maybe modify, do some adjustments to the plan as was originally written.
Sense. Thank you. Yeah. I see.
As far as reports go, the provider that does the mental health providing for the OPC clients actually does a report each time that client is coming to court. And that gets sent to me. I place it on the docket, included in an envelope, and the judge gets to see that in advance. So we meet, as I said, every other Wednesday. And after the commitment, the judge had said something, Judge Anderson had said something about the length of commitment. The first time a person comes in, it's an automatic 90 days, but of course the psychiatrist can ask, or the treatment team can ask for a continued commitment, which we have another hearing, and then that's a yay or nay. And like Nick had said too, we go up to 2 years, can go up to 2 years as well. And with COVID, we've kind of automatically, or the psychiatrists have kind of automatically done the 2 years, so that we don't have to keep, or they don't have to keep coming back and forth. But if they think that they're doing well, then of course the treatment team can ask the judge if we can cut it, or if they can cut it, we do. But as far as reports, statistically, we do that annually, but otherwise we do it every time we're bringing somebody to court. And coming to court isn't necessarily for punitive, it's not for punitive reasons.
Right.
But more for encouragement and great job and things like that.
So every time somebody's coming to court for their regular check-in, is something that's gone in writing to the judge to prepare the judge for that?
Yes.
Is
The
it?
case managers from CSS do a wonderful job of typing up a report. It's just a real simple form, like Carol was talking about. Are they compliant with medications? Are they following treatment recommendations? Are they coming to their appointments as scheduled, etc.? So they're great reports. They're good reports. And she's very appreciative of that too. Mm-hmm.
I have a question of some of the folks as to who prepares the report and who's responsible for delivering it. In our court, we have the supervisor, not the case manager, submit the report intentionally, so that if there's negative reports, it doesn't affect the relationship between the patient and their case manager. Instead, it comes from the supervisor. But how do other folks do that?
It's for Summit County, Akron, Ohio, it's a combination of whether it's a supervisor that would complete the report or a case manager. It's typically who's most current on the case. And the client does not see the report. And it's really Judge Stormer's call whether she wants to acknowledge some concerns or not compliance. Sometimes she doesn't even, she'll just focus on the positive. We just want to give her an honest, representation of how they're doing. And it's really up to her how she wants to address it. And we respect that.
And we do the same thing in Lorain County, I think, because Judge Walther visited Judge Stormer in Summit County. So that's kind of what we hear a lot is what Judge Stormer does in Summit County. But we do the same thing. Our case managers prepare a report off of a form to give to the court ahead of time that the supervisor actually reviews and sends to the court, and the judge and the team can review it ahead of time. So we have a very similar format to Summit County.
Yeah.
And we meet every other week as well. So that's every time that we meet. During COVID, we're doing, the clients are coming every other time. So they're staggered to help with the case managers who are helping them get to court or get on the Zoom. But normally we'd be everybody every other week. But we're very similar to Summit County.
And then in Colorado, we have to get so for the first two civil commitments are up to 90 days. And after that, up to 180 days. And then theoretically in perpetuity, if somebody needs to have court-ordered treatment for that long. And both the psychologist, one of the three of us, and if the person's on court-ordered medicines, and right now I think 80% of ours are, then the med provider, if that med provider is a nurse practitioner, then it has to be co-signed by a psychiatrist. Both send a letter to the judge no later than 30 days ahead of time. And the client can ask to see a judge or a jury at any time. They almost never do. And almost all the time when they do, the judge finds in favor of the treatment providers. And so I know it's different from state to state, but again, about 80% of our people on court-ordered medicines and about 90% of the people who are on court-ordered medicines are on injectable medicines because of lack of taking them in the past, lack of compliance. But we have to send those letters in. Both mine and the psychiatrist or nurse practitioner's letters are about 2 pages each. And we also have to give it directly to the client, have them sign a client right thing that says that they received it. And yeah, I think that's about it.
Interesting. Yeah, so, one thing I'm noticing and hearing a lot of people's responses is that it sounds like very often the reports are not coming from the monitor themselves. They're coming from the case manager. They're actually coming from providers. And, to me, that feels different than what Nick's describing in that the judge is not going to find out from a report from the case manager or the provider that the person is not getting the care they're supposed to be getting, right? The whole idea of upholding this as a mutual commitment seems easier when you're actually getting the information from the monitor who's not a member of the care team rather than from someone who is a provider to that person. So I guess my question to those of you who are true independent monitors who are not functioning as members of the person's care team in any way is whether you feel you have an opportunity to let the court know when you feel the person isn't getting the treatment they have coming to them that's been promised to them in their treatment plan. And if not in the form of a written report, what form would that take? How would you exactly let the court know that you have concerns about the quality of treatment a person's getting? Anyone want to take that one on?
Yeah, I'll take it.
Great.
What we usually do, or what usually happens after court, we have a meeting and we address some of those concerns, or I would address some of those concerns and ask, is so-and-so getting this? Why don't we try this? It's a very good working committee, a good collaboration. And the judge is also very good at getting involved with it too, by asking, what about this? Can we try this? And we have one case in particular that we're working on that we're trying to get into a little bit more long-term placement as far as hospitalization, so that this person can get stabilized. But we do a lot of brainstorming too after court. So that seems to be very beneficial. And if I see something that I think maybe they could benefit from, I've got Stephanie right there, and we can bounce things off of each other and then bring it to the court, to the team. So that's been real effective, in my opinion. Stephanie, I don't know, would agree or not, but it's been very effective that way.
Yeah, interesting. Anyone else want to speak to what they might have had to do or what they would be prepared to do if they needed to let the judge know that the person was not getting the quality of services that the judge expects?
So this area, we haven't been able to do this as much. I know, like I would usually get to court a few minutes early, or like she said for a summit, would stay after and talk to the judge if I feel like, and he's even brought to my attention sometimes where he feels or has questions or concerns. I do like the idea of a separate report from the monitor. Because we meet so frequently, I'm not sure, what the parameters around that should be. But we have a pretty good relationship as far as, communication. So whether that's an email, a phone call, when we were in person, before or after, we could have a conversation. But I'm not opposed to the report and the way that Nick talked about it. I just don't know, because we meet more frequently. I'm just not sure what that would look like.
And Ariel, do you feel like you could actually communicate with the court at any time by email or by phone if concerns?
Yes.
That's good. That's the most important thing. Is there anyone who does not feel that way, that feels like there's a barrier?
I have a thought. One of the things that I think, going back and looking at our collaboration with the courts, is that we developed that over a period of time before we even started implementing, where we had meetings with the entire team. And so that helped to create the foundation of communication between the county council, public defender, AOT court, the judge, certainly, and the treatment team, to kind of create a platform for sharing things. I think Judge Anderson has always done a great job in holding the treatment team accountable for everything that they say they're going to do. So I think that with the transparency that has existed, and with those routine meetings that, especially in front loading those meetings, it makes it pretty easy. There's a fluidity in being able to ensure and trust that all parties are doing what they need to be doing and what they say they're going to do. But I think that at least in our county, I think that has in many ways been driven by our judge.
Okay. Has anybody ever actually had a situation that they would maybe like to share where they've actually had to deal with a problem of a provider not upholding its responsibilities, where you had to let the judge know and hope the judge would intervene and let the provider know that more was expected? Has that ever come up for anyone in a way that makes a good anecdote? Maybe.
I can talk about a little bit about our mental health authority, who doesn't seem to be interested in, this is New Orleans, by the way, Janet Hayes, New Orleans, Louisiana, and doesn't seem interested in participating in the AOT program in terms of providing services and case management. And interesting, because our law actually writes the mental health authorities in deliberately, because
Yeah,
the intent of the law was always that the mental health authorities would have some oversight and some control over who over evaluations and who would be deemed eligible for the
yeah,
program. And so we have had some meeting. I facilitate our board meetings, and so you know, not only are they not interested in participating more, but they're also now asking that, you know, I sort of refer any calls that I get over to them so that they can evaluate the patient in their clinics and determine whether or not they're even eligible for AOT, which is kind of interesting because when she mentioned that, I said, well, how, you know, they don't go to your clinics. I mean, if people come to me after they've exhausted all other possibilities, including that one. And she's saying, well, you know, send them to our clinic. We'll have them evaluate and so on. I said, well, they won't go to your clinic. And she said, why won't they come to our clinic? You know, and I was like, because a lot of them don't even know they're sick. Why would they go to your clinic? You know, so the judge does not step up to intervene to do anything. So, I mean, it's not, you know, we just don't involve them. So we kind of work outside of that, even though they are a member of our board because the law says they have to be. So it's a little bit, we have a lot of struggles.
yeah. So it sounds like you're describing not a situation where somebody is not upholding their responsibilities under a particular court-ordered treatment plan, but rather your frustrations with getting the county department to take part in those plans in the first place, where they just don't seem to want to do it, so that they don't get to the point where they are court-ordered to do it.
Can I ask Shannon a question?
Of course.
So that's very interesting to me. Have they said, is their issue that it's because the order isn't person-centered, or have they really said what they're, because I understand the eligibility point, because we do have a little bit of that issue with us, but we're trying to figure out what we can do with that. But I'm just wondering, have they said anything else as to why they're just so resistant to it?
No, they have never said anything, you know, sort of upfront about that, but I think there is an element of that going on behind the scenes, not only with the mental health authority, but with our entire, you know, Louisiana Department of Health and Office of Behavioral Health, and that everything is leaning toward patient-centric treatment and care, and so it kind of leaves out all those people who are not able to self-direct. So.
Okay. Yeah, that makes sense, because I know we're very, you know, person-centered, but at the same time, like, I know we're really working with the criminal justice department, like our district courts, to try and collaborate and say, like, look, we know you are saying they have to do this. Let's come to a middle ground so that way we can get the people the services that they need. So that's really unfortunate that they're doing that. I just thank you for sharing. I wanted to get a little more info on that.
Yeah, and that's very interesting that you say that, because we're realizing now that while we did not want to have the criminal justice system as our #1 referral source, it's looking more and more like now, because the hospitals are not referring and we're not getting cooperation even from other individuals named in the law that are supposed to be working with us. Well, not supposed to be, but that it's named in the law that they must work with us in order for us to be able to even file petitions. That it's so sad but I think we're just going to have to do more of like what Miami-Dade has done, and and populate our program through people who are criminally involved, and hopefully uphold data that can then convince the state and our hospitals and doctors that the program really works. We didn't want to go that way, but it's kind of looking more and more like that's what's going to have to happen.
Yeah, you hate to get to a point where a person has to be in the criminal justice system, has to have a pending charge before they can be a part of it. But believe me, I know everything you've tried to make happen in New Orleans, and I'm sure you wouldn't have reached that conclusion if it wasn't a last resort.
Janet, could I jump in and ask a question of you? So are those people then that are coming to you through a court order criminally, are they still civilly committed to AOT, or are they in the program under the criminal court order?
Well, that's what we have to work out. And so I imagine the judges are probably not going to want to dismiss charges and want to have some control over the individuals that, you know, that are, you know, that are under their system. But this is municipal court, mostly municipal court judges. So these are folks who are there on minor misdemeanors, you know, or who have committed, you know, basically nuisance crimes or you know, those sorts of crimes. And there are judges who are very, very interested in diverting and deflecting them away from the criminal justice. So we have yet to work out what that's going to look like. I mean, sadly, we've only just started having these discussions again with them in the last month. But I know that the Miami-Dade folks have a very robust system of diverting, deflecting people from criminal justice into AOT. Now they haven't really built up the probate side yet. So I'm going to try to meet with them, what they're doing, and see if we can't use that as a blueprint moving forward for what we might need to do here. Ideally, the judge would drop the charges if the patient agrees to go into the program and successfully.
Prosecutor would have to agree to that.
The prosecutor.
Right. So
Yeah.
I guess what I'm trying to figure out then, so they're not going through like the typical petition process then with going through the crisis unit, getting the opinion signed, like they're just being court ordered directly into AOT.
Yeah, our law allows for that.
Okay.
There are 5 different ways a person can come into the program, and one is if they're involved in the criminal justice system.
Yeah, but what doesn't change is there's still got to be a finding that the person meets those civil commitment criteria.
Be filed.
Right. Right. So there's still got to be a clinician who's evaluated that person somewhere in the process and says, yep, this person meets criteria. I found that and I'm willing to come to court and tell you so.
I think in our case, well, now I'm not sure though, because I am in Florida and I am still just figuring out these laws, but
Right.
you know, the Treatment Advocacy Center knows I'm looking for a loophole to not have to go through the crisis unit. So
Yeah. And
I'm gonna figure
Florida,
it out.
Florida law is different than any other state in that you have something that allows a criminal court judge to order AOT themselves. They don't have to transfer it to probate court, which is why, you know, Judge Leifman in Miami-Dade has been able to run his own AOT program, even though they can't get probate court there interested in doing it. They just do it out of the criminal court for people who are facing charges. But it is limited to that universe, which is, you know, a real shame.
Right, but if I could get like Judge Sweat to use it and then just bypass, then we could do that here as well if we switch to the
Yep.
criminal side.
Yep.
Okay.
In Florida, yeah. Judge Sweat could be, who is your criminal court judge for everyone's benefit, could be doing these purely in criminal court. Is there anyone else who has had experience in their county with bringing people in from the criminal justice system who are like stuck in competency restoration limbo, where the idea is let's dismiss the charge rather than put them through competency restoration, and let's see how it works with AOT and just move them to civil court? Has that been tried anywhere that anyone's working?
Well, in Nevada County, we're just trying it now. It's taken a while for everybody to be aware that AOT exists. And, yeah, we have several misdemeanor incompetent defendants. And now we're trying to refer for alternative treatment, either conservatorship or AOT. I'll let you know how it goes in the next month or so.
Yeah, we'd love to stay involved with you on that, because we really feel like that's the next frontier. It's a place where there is such a great opportunity to use AOT that isn't happening. But we also don't want to see those cases overwhelm our AOT programs where you reach the point where you can't get into AOT unless you have a pending criminal charge.
Right.
We have seen, this is Heather in Nevada County, we have seen that it definitely does not work if the person is going to be incarcerated the entire time. They need to be able to be out in the community to provide this.
You've got to get the prosecutor to say, we're going to dismiss this charge.
Yeah.
And they should know they're dismissing it without prejudice, which means that they could bring it back at some point in the future. If the person, reoffends, they could still bring back that old charge.
Not if it's a misdemeanor. You only get one dismissal. Felonies, you can dismiss and then refile.
Gotcha.
At least one prosecutor's credit, they just today dismissed a felony because the person got has a temporary conservatorship.
Yeah.
So.
Is that a California thing or is that?
Yeah. California.
So other states could have the charge.
Dismiss misdemeanors without prejudice. Yeah, I think that's right. Go ahead.
About conservatorship or dismissing the charges without prejudice. In Louisiana, the conservatorship process here would be an interdiction, kind of the same thing, and it's an interesting tool that we might want to look at.
So I was referring, Amy and I were talking specifically about the idea of dismissing the charge without prejudice, asking the prosecutor to do that. I think in most states that would be doable.
It's really necessary in California because in order to find placement, if there's a hold or a pending criminal case, often facilities won't accept the patient.
Right. That's a great, all the more reason.
Judge Anderson, what about deferred judgment?
Yeah, I don't know how that goes with placement. I was going to ask you that.
Well, I think with deferred judgment, they're not incarcerated, so
Right.
placement is okay.
And that there's California now has a relatively new mental health diversion statute that we're just sort of implementing, which allows most any type of case to be diverted if it can be in the benefit of public safety, security, and treatment plans seem reasonable.
Brian, if I could piggyback on this discussion, I know that Treatment Advocacy Center has talked a lot about using civil commitments as a replacement for restoration to competency.
Yep.
In Ohio, it's a big issue for me because we can't get people into our state hospital on a civil bed because they're full of restorations to competency. One of the issues that I was thinking about when Dr. Townsend from Colorado was talking about with his high percentage of people on forced med orders, I think a conversation for this group and other groups in AOT can be, if you do outpatient restoration, I think one of the keys is to have a more robust forced medication system than at least we do in Butler County. That is one of the advantages, so to speak, if our people under restoration go to our state hospitals, we can do a forced med order, and that can often quickly take somebody who's not doing well and get them better fairly quickly. If we could do that better in the community than we do right now in our county, using some of the information from Colorado and other places, I think we could dovetail those two conversations together at another date.
Yeah, it's tricky. I mean, I think to make that work, you'd have to keep the person under competency restoration, have it be competency restoration in the community instead of a dismissed charge to where there is no criminal justice hook at that point, and just have them under a pure AOT, which in a lot of places is not really usable. You can't really combine forced medication order with a pure AOT. I think in Colorado you can, right? But there's a lot of states that don't allow that. Forced medication at the end of the day requires, when you have a competency restoration situation, it's a little different. But when a person is a purely civil patient, you can't do forced meds without a finding that they lack capacity to make treatment decisions.
Right.
That's part of what they're finding in putting someone under AOT. So
I was intrigued by Dr. Townsend's discussion of the forced meds because I for the benefit of our respondents, I wish we could utilize it more effectively from people in the community. And I'd be interested to see how they do that in Colorado.
That's interesting. Is there a, Brian or Amy, is there a list of this group and like contact numbers? 'Cause I'm happy. That's sort of my job as a supervisor to, reach out, and I'm happy to do that anytime.
Yeah, send it to us and we will get it to everybody who attended this meeting. It's no problem.
So what do forced meds on an outpatient basis look like in Colorado?
So it used to be a really easy thing to explain, and then COVID hit. And also a newly released Senate bill that has, so if somebody's on court-ordered medicines and they, for example, don't show up for their shot, or their shot is at their home and they refuse the shot, prior we could send either a welfare check or a sheriff or a police officer out there and get that done. We have a new Senate bill that talks
In their
about
home?
excessive use of force.
Yeah.
And so the sheriffs, especially much more than the police, are really hesitant to do that now. So we sort of use like a lot of persuasion, I guess, these days. But we don't really have that problem very often. For the most part, people, because we're able to get home health medicines through nurses, which really helps. And then, you know, the rest of them come in to the mental health center and get their shots. But we don't have that problem very often. Where we see it more often is when we have somebody who's in the community, they're not currently on court-ordered medicines or a court-ordered treatment certification, and we're trying to establish that.
In the common pre-COVID practice, would they actually medicate the person at their home, like knock on the door and say, we're coming in, we have this order and we're going to medicate you here and now? Or would they take them to a facility?
So no, they would evaluate them. We always leave that at the discretion of the law enforcement official. So the emergency mental health hold in Colorado is called an M1, and about 50% of them are done by treatment professionals like us, and about 50% are done by law enforcement officials. And so we usually leave it at their discretion to do that. Now, in the wonderful world of COVID, we can use what they call these electronic M1s, which is the same thing, except for obviously we don't have all of the, we're very, very limited. But we've had pretty good success, I guess, doing that, especially given everything that's gone on. And it's a very accepted practice in the state of Colorado. And one of the things I was noticing where some of this was going on is a lot of the lawyers, so when somebody is certified for treatment, court-ordered treatment, they automatically get a court-ordered attorney paid for by the state. Most of those attorneys, like a lot of us who've been around, we've worked with them 25 years, right? And a lot of them absolutely love the treatment that their clients are getting with the mental health center. Especially, I heard a lot of people say like they're members of the ACT team, like they love the ACT team because they get between 2 and 4 hours of treatment a week. So we don't really have the adversarial relationship that I've heard a lot of other people speak to. But again, with the Senate bill and with COVID, it's been a lot more of a challenge.
So just to circle back, would the cops go in, hold the person down in their home while the nurse, or they'd be brought to a facility?
No, they'd be brought to an ED or an ER, and we don't, and it's not automatic. So we sort of see like, did they miss their medicines? Have they missed appointments? Because they have to see each of our psychologists once a month, their medication provider about once every other month, and their case manager therapist once or twice a month. So if we see a pattern, then we'll do it. So there's no like really decision tree. We sort of just use, clinical judgment as to, how concerned we are about that client.
Yeah.
Is it emergency medication or is it their prescribed medication?
No, it would be prescribed medication. The only time that emergency medicine is used would be if it was in an inpatient facility. And with All Health Network that I'm a member of, we have a 16-bed facility that's called Bridge House, and they can do all medicines. And also, like Nick was talking about, we have 2 state hospitals in Colorado, and we're also backed up with the civil commitments, and so it's really hard to get people in there. But no, it would be the quote-unquote emergency meds would only be in an inpatient facility, and we have many of them, many hospitals that have small mental health parts of them.
But again, people should keep in mind there are many state laws that would not make that possible for someone who's purely under an AOT, because the AOT laws do not have explicit terms that say that they do not authorize involuntary administration of meds. And that to make that happen, it would require converting the person to an inpatient commitment, find they meet the criteria for that. Then once they're in the hospital, every state has a process for involuntary medication.
And Brian, I think some hospitals won't force treat unless it's an emergency. It seems like a lot of hospitals are going more in that direction. I hear back and forth. In Louisiana, it depends on the hospital and it depends on the provider. I don't think there's anything in our law that prohibits it. And I can't say for 100% sure, but I have heard that ACT teams will force treat in the home or force medicate in the home. mom whose son, this was a while ago, that team used to come and give her son a shot, and if he didn't want it, they were giving it to him anyway. So maybe that's because she was there to kind of say, you know, you don't have a choice. But you know, we will, I mean, they do send folks back to the hospital, but I know hospitals here that are saying, if you don't want to take your medications, you don't have to. See ya.
Yeah.
Just
All right, so we're over our hour. I hope this has been instructive and useful for everybody, a good use of your time, and we'll see you again when we do this in 4 months. If anybody wants to stick on or have some other issue they want to raise, and if there are folks who want to continue talking about that, that's fine. Otherwise, I guess we'll see you soon. And of course, we're going to have many AOT Learning Network events that we hope to see you on in the interim between now and the next time we do one of these calls. But anybody else want to raise anything before we sign off? Or
I'm just wondering, Brian, if I can get something, like, I don't know how you set your agenda, but when I talked to you and when a few of us talked to you and Amy some months back, one of my passions is that, like, if you're, again, you can be court ordered for treatment, get your medicines outpatient. You can also get your medicines if you're in prison, but in jails in the state of Colorado, there's no enforcement of that. And so as a result, people decompensate in jail, like end up in 23-hour lockdown. And so I just would like to see if there's any other jails, if there are jails in other states that are able to administer those medicines, because I'd like to move something like that. It's been my passion here for 25 years to find out what other states might be doing.
Anybody have any experience with that?
Our jail does provide medications to inmates with serious mental illnesses only because we're under consent decree, and we're contracted with the Department of Psychiatry to provide 14 psychiatrists in our jail. And it's still we haven't solved the problems that we had before. So anyway, I just had to throw that in there because jails are still not the answer for this population. But it's only because we're under a consent decree and that we have jail monitors who are looking in all the time on behalf of DOJ to make sure that those things are happening. Otherwise, I know that other jails across the state are not doing it. There is one, Elaine Hunt Correctional Facility it's up near Baton Rouge area. And they have as far as jails go, they do have the best mental health services in the state, and they are, you know, they do provide medications for people, although the people can still refuse their medications.
In our county in California, we've got a pretty good working relationship with the jail, and they do provide medications, and they'll coordinate with, it used to be they only gave the medications that they had in stock, but now over the last year or two, they now provide the prescribed medication whenever possible, especially if it's brought to the jail by the family or by the service provider.
And Aaron, if you want to set up a meeting with us to discuss this in greater detail, we can do that, and we'll try and do some research in advance of that.
I would absolutely love that.
Yeah. Sure. Reach out to Amy and we'll schedule something.
Thank you very much. And thank you to everybody who joined today.
Yeah. Thank you.
So Brian, I have something burning up.
Okay.
So at our last meeting, we have a doctor who participates from the University Medical Center, the state hospital here, who has the largest catchment area for folks who would meet criteria for our program. And he's saying that they're seeing a huge uptick in people coming in with substance use disorder, and also from other states, which is kind of interesting. So we're way above bed capacity or beyond bed capacity. But here's the problem, because we were talking about AOT, and in Louisiana, you can't. We call the Physician's Evaluation Certificate PEC. I'm not sure what it's called in other states, but that's the order that allows physician to get someone on a 72-hour hold into a bed. And so what's happening is we're getting a ton of people coming in. They're high, and they're on all kinds of different stuff. They get detoxed in the ER. After 2 or 3 days, they're feeling like superstars, golden, right? not presenting with serious mental illness because they're feeling great. The doctors are not feeling good about keeping them any longer in the hospital any longer because they meet criteria for legal competency. They're letting them out. And then, of course, because of an underlying serious mental illness, they're going back out and coming back in again because they start self-medicating. And so they're just being, I mean, this is like just, they're just being like, they're not even getting into beds. They're just being recycled through the ER. We have major problems with boarding in our ER now that we weren't having before. And we have a psych ER and 60 beds at that hospital. And it's just, its population is absolutely unmanageable, but probably most of them meet criteria for AOT. I don't have any quick solutions, but even the psychiatrists are saying, you know, even if we found a legislative fix around this, it doesn't solve our problem because we still have nowhere to discharge them to, because a lot of these folks need residential treatment facilities. They need a housing continuum of care, and we don't have enough housing, and you know, all of these things. So is there anybody else, has any ideas about, you know, how we can unbottleneck this particular cog in the machine? I know everybody's kind of, a lot of us are experiencing the same problems, but you know, it's just.
Yeah. And you're talking specifically about people who have serious substance abuse issues.
We're seeing more and more of that.
Yeah.
Unfortunately, people are out there self-medicating. And I mean, we have a huge meth problem in New Orleans right now.
Right.
And can't control the supply, and they're coming in. People are getting all kinds of cocktail drugs and overdosing, and it's fentanyl, it's everything under the sun. And but you know, probably half to 2/3 of these folks, maybe more, have an underlying serious mental illness, which is why they're using in the first place. But we can't get below the substance use disorder to get to the serious mental illness, to get them into a bed that might get them into our program. I mean, that's a big might, because we still have cultural problems with, you know, the doctors just are like, they're not really excited about it. But then the doctors are saying, well, you know, these folks need residential treatment, you know, like 3 days in a hospital is not gonna solve their problem. They need 6 months or a year in a residential treatment.
Yeah. Yeah.
You know, we're working on maybe potentially using the IMD waiver to build up capacity for more residential treatment facilities, but you know, we're a long way away from that right now.
Yeah, it doesn't sound to me like you're describing a really good population for AOT anytime soon, at least not until, you know, the inpatient care they need to be stabilized to where they could be AOT candidates down the road. But I guess I don't really see AOT as the solution to the kind of systemic dysfunction that you're describing. That's specifically that part of it anyway.
Yeah, it's unfortunate because the family members are all saying, these folks are, even when they do get into a bed, the family members are saying, the doctors are telling them that the individual doesn't have a serious mental illness. They're there on a substance use
Right.
issue. And the family's saying, but my son has schizophrenia. That's why he's in the doctors are saying, nope, here for substance use disorder, for detox, and out they go.
Yeah.
I don't know. Anyway, but even the ones that are eligible, we're not getting those either. So we have a huge problem with the doctors who are just they're not excited about it. And we've tried.
I'm sorry to hear that hasn't changed.
No, so that's why we're going to go to the criminal justice.
Yeah. You know, I was down there and tried to get them excited. More
than once.
They're very cynical.
Yeah. Well, thanks for listening.
Yeah, sorry we can't solve that one.
No, I know.
Thanks, everybody. Great to be with you, and appreciate you all sticking around so long, and see you all soon.
Yep. Thank you so much.
Take care.
Bye. Take care.